Good afternoon and welcome to the final session of Decoding Digital. So far you've had lots of very interesting talks. I've caught some of them. We've covered lots, the talks have covered lots of different subjects, from digital impressions to digital imaging. I caught a great talk on digital aligners this morning, on single tooth dentistry, and also on digital implantology. Really what I'm here to do today is to talk to you about a solution that we've been using in the practice for approximately 2 years now, which is called BridgeBase. Hence the name of the presentation, Bridging the Gap. And bridging the gap, I think, is quite an appropriate way of talking about it, because not only does this bridge the gap in terms of filling the space, it's also bridging the gap between your analog and your digital workflows for any final restorations that you're making. So I'm going to highlight this much more during the presentation, but initially I'm just going to basically show you a picture of what this is like. So BridgeBase is a titanium bar that you can see there. It's a bar to support a full arch or partial arch prosthesis, but it's much more than that. And I'm going to talk you through, again, a little bit more in terms of the detail of how it works, and touch a little bit more on what Michael showed this morning in terms of his presentation. I'm going to do a little bit more of a deep dive into BridgeBase and how this works. So really, I think the other part I mentioned that's relevant with BridgeBase is this goes through both your digital and your analog workflows. And it's a way in which we certainly have reached the point which we have been looking forward to in our dealings with full arch. We've been looking forward to having the option of having a fully digital process from the patient coming in to the patient coming out, and not having to take an analog impression. A little bit about me. I work in private practice. I'm a GDP. We are a private practice in Clapham and Balham. You can see some of the team. You can also see my business partner there, Nick Sisodia. As well as doing that, I'm a tutor on the Royal College of Surgeons diploma. I'm also work on the I'm a lecturer on the Masters in Aesthetics program at the University of Frankfurt. A big thanks to those gentlemen you see on the screen. So really, you will all know this person in the middle of the screen, Paolo Mallo. When he first brought All on 4 to the masses and it became something we did as Dentistry, it had three really important messages. The first thing he talked about was simplifying treatment. The next thing he talked about was reducing costs. The final thing he talked about was reduced treatment time. And we're going to hold those things in play, and we're going to see how this solution, BridgeBase, relates to those three things that were part of the original All on 4 protocol. As well as that, we know from him coming out with the protocol, many other companies have adopted this and used it in lots and lots of different ways. But from when it came out, and I think the first cases were done around the early 2000s, possibly 2003, 2004, what has changed in terms of the restoration? Because we're now in the age where it's possible to have robots that can jump, dance, sing, somersault, carry out parkour. But in this sort of environment, why is it we're still using these tools for our full arch restorations? We're still using these processes. They're tried, they're tested, they work, we know they work, but is there a way of us updating or upgrading what we do in order to take advantage of the digital workflow that's available to us? What we know when we look at what's happening in the world of implant dentistry, we know we're very comfortable looking at digital surgery. We're very comfortable looking at guided surgery. And again, there've been plenty of talks and lectures that address this. But with digital surgery, why is it we suddenly have analog restoration? A typical impression that you see here, another typical impression that you see here. And we're going to challenge this thought that actually analog is better than digital. We're going to talk about the advantages and disadvantages of using both processes during your full arch restoration. So if I was to show you something like this, you'd see that no one would bat an eyelid if I showed you this, this way of restoring a full arch, which is, you can see there the verification jig, you can see a screw retained try-in, you can also see there a special tray. But really, just to remind you all that planning is really key with that. Making sure that you plan your implants correctly, because the whole process, and again, the people who've gone through this before today, Michael's talked about it, Clive has talked about it a little bit, making sure that the planning is done properly is key. Now, the questions that you should ask yourself when someone comes along with something new, if someone is proposing you do something different, I think there's three key questions you need to ask yourself. The first question you need to ask is, what problem are you solving? Unless you're solving a problem then there's no point changing. And I'd understand if you're sat on the side wondering whether you should do this or not. You need to ask yourself what problem you're solving. The next thing you need to ask is, what process are you improving? What part of the process that you're doing, so we've moved on from solving a problem, we're now improving a process. What part of the process are you improving in your practice? The other thing you need to ask is, what are the additional benefits that you gain in practice from doing this? If we look at the different problems that you might be solving, and what you can see here now is an image or a video playing of a full arch impression. If we ask our patients what they prefer, whether they prefer to have this done to them, which is a full arch impression, or they prefer to have a scan, we know that the research overwhelmingly shows our patients prefer to have digital impressions to analog impressions, especially ones like this for full arch. The other problem we're solving is when you take this impression, you can only see the top of this. What you can't see, and this is one of my impressions, is you cannot see the underside. You cannot see the voids, the blows, the areas where you may not have seated the jig correctly. You can't see this at the time. You have to accept that, you have to assume that what you've got is correct, and you get one shot. And again, I'm going to show you another one of my impressions there. And you can see on here where actually some of these, where some of the impression posts are not sat correctly. You can see there's a little bit of impression material that's got underneath them. You can see air blows around them. So this is again using the technique I've just shown you in the video. You can see that actually it's not perfect taking the analog impression. Speaking of impressions, I'm going to disassociate myself from the next few because a technician friend of mine, Jamie Brain, sends me pictures occasionally, and these are a few from the recent collection he sent me. And you can see that actually, an impression analog does not mean it's accurate. You can see here the denture's not been positioned correctly. You can see here that the material's not set. And finally, you can see on this particular one here that actually, in some way, shape or form, there's been no the impression post has not been picked up, and I'm really not sure what I can say about this other than there's a lot that could be improved with this process. The other thing that we're solving, which is a common problem, Michael touched on it, some of the other speakers have touched on this, is fracture. We're all worried that our full arch bridges that we put in, this is going to happen one day, and we're going to have to deal with the process of repair. We're going to have to deal with a frustrated patient. So if I just show you a case from start to finish, or if I can show you parts of a case, you can see here some teeth have been removed, some implants have been put in, a framework has been made, and this is a milled framework, one of the very early milled frameworks we were using in the practice. And this is the very case that I showed you, where actually that's on the day of fit. And if we look a little bit further down the line, this is the same patient where it's fractured. We can see another patient here again, where there's been a fracture. So with Bridge Base, we are going to go some way towards solving this problem, which I'll discuss in a second. In terms of the other problem we're solving something that I think is a conundrum within dentistry, which is material science. There's lots of different materials, they all have different strengths, they all need to be handled in a different way, and different technicians prefer different materials. So when we look at it, one of the things that we realize is when we look at this in great depth, there is no ideal material for a full arch restoration. The ideal material would have all of these properties that you see here, but the issue that we have with that is no one material does all of these things. So what we try and do is we try and have hybrids. So we use combinations of materials, so we get the best of one material and the best of the other and combine them. And again, this is where Bridge Base might be a solution for you to consider. It also allows us to access a whole range of different materials that you can see here. So what you can see here is sorry, I'm just going to go back one slide. So it allows us to access a range of different materials that we can get through digital dentistry and CAD/CAM. We also know, for instance, in terms of zirconia, here you'll see a zirconia bridge that I fitted in the practice, and you'll see the issue that I had with it when this section here comes off. You can see this is some of the issues that we have with using purely zirconia. So if we look at what Bridge Base does, Bridge Base allows us access to use zirconia for full arches by reinforcing it with titanium. So what you can see here is the Bridge Base, which is essentially a milled titanium bar, and on top of the milled titanium bar, we can put a sleeve. I tend to use zirconia sleeves in the practice, but other materials are available. But the sleeve can be milled, which gives you access to a wide variety of different materials that can be used in this indication. So what we're getting the advantage of in bridge base. We're getting the advantage of titanium. You can see the properties we talk about here in terms of the biocompatibility, the strength, the ease of milling. It's not particularly repairable. And again, the other thing that we're getting is we're getting these advantages from using zirconia. So the combination of these two materials, zirconia is what I use, is you've got on one hand the strength provided and support provided by the metal bar. You've also got the fact that the screw access hole can be programmed in a way that makes the veneering material, which is the zirconia over the sleeve, as strong as possible in all sections, because angled screw access screws are available to put the screw access holes in the ideal position. So you've got that element of design and control and strength. On top of that, you have the aesthetics that come with zirconia, and on top of it you both have two biocompatible materials, which again we know are essential and work very well for our long-term implant health and for the implant stability, both hard and soft tissue. So it looks something like this when it comes back from the laboratory. A titanium sleeve, and here you can see that the sleeve has been roughened or sandblasted in order to make it, easy to cement into the titanium bar, can be then cemented into the zirconia sleeve that you see there. Let's ask ourselves the next question. What process are we improving? What's the process that we have taken, we're looking at, and that we're going to improve in terms of our full arch and partial arch work when we're doing this digitally? The process we're improving, I think, is really, really illustrated in this next case I'm going to show you. This next case is one where we've placed some implants, and having placed some implants, the patient has a provisional prosthesis. And then when the patient has a provisional prosthesis, we're beginning the process of restoring the patient. And as we begin the process of restoring the patient, we need to take her provisional that she likes, she's comfortable with, she's happy with, she is approved, and turn this into a final. What you can see here now is the process I used on that occasion. We've talked a little bit before about the analog process of the special trays, verification jigs, etc. Those are the impressions that you see in front of you. What I did was I sent this all off to the laboratory, and in sending it to the laboratory, I said to them, what I'd like you to do is to copy in wax the provisional prosthesis so that I can then put this into the mouth as a screw-retained bite block and have a combination of a try-in and a bite block at the same time, because we have all the information we need contained within the provisional restoration. I think I imagined I'd get something back like this. What you can see here is a screw-retained wax bite block, and you can see here the process I imagined we would go through, and the process would involve taking a bite registration from this and then being able to proceed with verifying the model and going through to make the final metalwork. That's what I imagined I would get, and that would be a fairly streamlined workflow. What I got back, though, was something like this. So you can see immediately that all the information that I've gathered and collected and that we've worked out, the bite, the phonetics, the tooth position, tooth height, tooth size, intercuspation, vertical dimension, all of that information has been lost, and we have to gather all of that information again. And I don't know if you've had this in practice, certainly I have, where a patient really likes the provisional prosthesis you give them. You then start the process of trying to make a final prosthesis. And when you begin the process of making the final prosthesis, you go through multiple try-ins, because first of all, the center line's correct, then the center line shifts, then the bite's correct, then there's a cross bite. And imagine doing this on dual arch. So actually getting to the point where you have a good, well-fitting provisional prosthesis. If we can get to that stage, then using this process or protocol, we can do this. We can basically copy the provisional to the final, which gives us the workflow that you see coming on the next screen here. You can see there, that's the surgical stent I've used, where the patient's approved the dentures before we've gone ahead and carried out this surgery, carried out by Dr. Guy McClellan in this case. You can see there the provisional prosthesis in place. You can see the try-in, and you can see the final. And you can see by having this workflow that we can go through one to the other all the way in a very, very smooth, organized and in a very smooth and controlled way, gives us the additional benefit of predictability from an aesthetic perspective. What are the other additional benefits? The other additional benefits come in terms of how you engage with your patients. And if we look at a talk from one of my patients that's going to come up now about one of the things that she enjoyed about the process of carrying out her rehabilitation.
Second meeting that you have with Dr. Wanendeya, you'll get to see what your teeth are going to look like. But this is done digitally. So Martin will bring up on a screen and it'll show you what you currently look like, and then it'll show you what you're going to look like. And it just blows your mind away, and it brings you so much joy.
In terms of your patient engagement, being able to show them what they're going to look like before and afterwards, and then being able to deliver that result, I think is a huge, huge benefit to you in practice. And having that aesthetic predictability, I think, is one of the things that being able to do this process digitally allows you to engage with. I've got to say a big thank you to Adam and Ross and the team from DNTL for that video there. So this is another case where what you can see here is the digital wax up. Then we're starting on the top, then the top in the middle, the brownish model you can see there, that is a printed model from the digital wax up. Then the next one along that is white. What that is we call that the prosthetic shell. What that is that's the physical manifestation of the digital wax up. And that's what we use to make what you can see on the bottom below what you see on the bottom is the provisional restoration. Then in the middle the try-in, and then in the bottom in the middle on the right on my screen, you can see the final restoration that we fitted in the patient's mouth. But the important thing about this is the process that we've been through, being able to go from one to the other, and keeping that information and transferring it from step to step. And mind you, with this, to be clear, the digital wax up has been done by a team who are based in Romania, who do a lot of my wax ups. The printed model has been done, again, that's been done in the UK. The shell has been made and the surgery has been done with a different technician, Jamie Brain. And the final restoration has been done with Steve Campbell and his team at Nexus. So there's 3 or 4 different technicians that have been involved in this case. But the most important thing is the thread of how it's been treated and the aesthetics that the patient has approved has been what we've been able to deliver. So I think this is a big bonus, is the predictable aesthetics on here. And I think the other thing is, there's other advantages which we'll talk about later, but the predictable aesthetics is something which I think is a big thing with Bridge Base. So really, when I started this process, we started with something small. What you can see here is a patient before and after. This is on the day of surgery. We've taken the teeth out, we've placed some implants. She's chosen not to have extensive bone augmentation to build that defect up. She's particularly nervous and worried about treatment. So what she's chosen as her pathway is to have some pink put in that area, to have an FB3 style restoration. What you can see here is the scan abutments we use. These are called Atlantis flow abutments that have been used. These have been connected up to the abutments, and from there we've carried out a scan. This has been sent to the laboratory, and the laboratory, this is Nexus Dental in this case, I've carried out all of those stages to give me the final restoration. So again, you can see here, this is a case we did very early on to try out the concept, to see how it works, look at the support, and this worked very well. And I think what surprised me was actually from just the one impression digitally, being able to go to the fit was a real game changer. And actually, for a long time, those of us who've been involved in implant dentistry have been looking for this magic bullet, this thing where full arch scanning. And for a long time, I think the scanners we've had on the market have not necessarily had the software and the hardware to cope, but certainly with PrimeScan, which is what we've been using for these cases, the PrimeScan has provided us with the accuracy needed to be able to carry this out time and time and time again over the last couple of years. So we've shown you a smaller case. We're going to look at a slightly bigger case here. And what you can see here is the patient at the start. And what we're doing with this patient is we are rehabilitating him. He has an upper arch that's failing with multiple mobile teeth, which have got obviously through periodontal infection. And through this, we're looking to rehabilitate his upper arch at this stage. As part of the planning, we've again taken photographs, radiographs, and an OPG that you can see there. You can see the state of some of the teeth that we're looking to remove and replace. And again, as with all these patients, we've talked about options, different ways in which we can restore and begin the process. So in terms of the options that we've talked about, we've obviously given him the option of keeping these teeth or removing and replacing them. He's chosen to remove and replace them, and as part of that, we've begun the process by using the photographs of his teeth and the photographs of his face to begin to plan how we're going to restore him. And the process begins with us showing him what he's going to look like and showing him before and after. You'll see here the video changes so that you can see him smiling and not, and you can see us just being able to show him what he's going to look like, give him an indication of what's going to be possible with him. Now, having taken that information from the two-dimensional realm, we now need to convert this to three-dimensional. This is where the initial scan, or the initial the initial scan that we've taken, the STL file is brought in and merged with the two-dimensional photo, so that we can then take that physical or that digital model and actually add it and bring it into 3 dimensions. What you can see here is a breakdown of the process. You can see his initial teeth moving around on the screen here, and then from there you can see how we've planned for a guide. So we've kept the canine teeth in so we can support the guide on those canine teeth when we're placing the implants. You can see here the wax up that we've decided on, and these again are all parts of how we pick up and break down a case into the different stages so that we can provide a digital restoration. You can see here the shell, and as you can see, the shell is a copy of the wax up, and that wax up is a copy of what we have shown him as what's possible in terms of his full arch restoration. I'm going to go very quickly through the surgery because this talk is not necessarily about the surgical side of it, it's more about the restorative side after the surgery's been done. So we can see the patient here at the beginning, we can see here we've got the surgical guide, we can see the shell here. This shell, again, just to emphasize, is a copy of the wax up, and what we do in the practice is use something like this clear acrylic stent. There's different versions of this, but this was an earlier version. We now use a slightly different version which is printed and attached to the shell and locates on the palate. But what this allows us to do is to locate the shell in the mouth at the time we are looking to pick up and carry out the final the restoration. Now you can see here the steps and stages. Patient at the beginning, teeth extracted, guide in place, and then from there, these are the extracted teeth. These are the extracted teeth next to the shell. You can see here the implants in place. Those are the positions that we've decided upon before. This has been planned digitally. You can see a welded bar and framework that we've used, and this has been used to make this here. This is the provisional restoration, and this, in some point, is the starting point of our discussion. What we're looking to do here when we've got this provisional restoration is, again, obviously place this into the patient's mouth. But if we spent all this time planning to put this provisional restoration in place, we need to, if the patient approves this and is happy with this, we need to convert this provisional to a final. And you can see here the provisional in function. The patient has taken this away, has worn it for a while, as again any adjustments have been done, is happy with the aesthetics, is happy with the phonetics, and we now need to take this a step further and actually just copy this provisional to a final. You can see here the before and after on the day of surgery, and you can see here again a before and after on the day of surgery. And again, the crucial aspect, and I think a huge advantage of BridgeBase, and obviously of using a digital workflow with this, is that we can we can transfer all of this information from the provisional to the final. And we've shown 2 cases where we've done that, and this case we're going to go into a little bit more depth as to how we do it. So what do we do? What we need to do is you need a prime scan, and you need certain scan bodies that you're going to see. These are the grey scan bodies. These are called the Atlantis Flow scan bodies. You can see here the patient, this is the healed ridge. You can see here the scan bodies in place. And what you're going to see now is some videos that come up where I'm going to talk you through the typical process that we use for this. So the first thing that we would do is we would scan the patient with the prosthesis. You do a scan of the upper prosthesis in place, and during the scan being very careful to pick up as much of the soft tissue in and around the prosthesis as possible. You also scan the bite. So what we've got now is we've got a scan of the upper prosthesis in place. We've also got something to show us the vertical dimension. The next thing that we do is we take off the provisional prosthesis, we attach the scan bodies, and we go through a process of scanning. Now, to be clear, there is a pattern that you need to follow, and again, a little bit like you can do a poor impression in an analog way, you can do the same in a digital way. So it's important that you follow the scan pattern, which is slightly different to the one you're showing here. This has been released, and I'll deal with that slightly later in the presentation. So what you can see is me here, first of all, getting an overview of the arch. Once I've got an overview of the arch, I'm then filling in all the little holes and trying to get as much information around each scan body before moving to the next step. So now what we've got is we've got the scan bodies, which is effectively an abutment level impression. We've also got the provisional prosthesis, we've got the bite registration as well, but the issue now is locating this abutment level scan that we've taken to the other scans. This is done in two different ways. The first way is this, is to scan the prosthesis outside the mouth. And when you scan the prosthesis outside the mouth, you get some very valuable information here. You get the vertical dimension, the tooth position, the screw access position, tooth shape, you know, and all of this information that allows your technician to build the next stage effectively for you. And then once you've scanned this, sometimes, and you can see it happening here, there's just a little area where it appears, you know, you can just see something appear very slightly. You can see the provisional restoration appear, or you can see the palate appear. You will see that happen again. It will just flash up in just a second. So you'll see that happen just there. And that means that it's linking, the prime scan is linking this scan of the provisional prosthesis outside the mouth to a scan of the prosthesis inside the mouth. And sometimes what you need to do is you need to go through these steps where you link the scans in the software. Now, one of the things that's important in this is that you have a really, really good technical team and technical support who understand what you're doing. So when you're linking the scans, you're picking on markings. And remember when I said you need to scan a lot of information in and around the provisional prosthesis? This is the time when you need to make sure that you've got information to link it both on the buccal and the palatal side. I'm going to cut to just a quick aside to show you a case where we've redone a prosthesis that you see there. This is the patient with the provisional prosthesis, and this is the scan. This is being done by Steve Campbell, and I think Steve might be working on that today if I'm lucky. But you can see here the provisional prosthesis, the scan bodies as we've discussed. Now, if we look very closely, when I've linked the scans in the software, and you'll see this come up, it hasn't fully aligned. So if your lab does not go through a process where they check things and look at things and make sure, if you look really closely, you'll see that the scan bodies are slightly to one side of the actual screw access hole. And Steve called me up and flagged me up on this, said, listen, I'm not sure what's going on. I'm not sure how accurate this is because I'm not sure where I can put one thing next to the other. You'll see the video zoom in ever so slightly just to show you the area that we're talking about. You can see there. You can see that the screw access holes are not fully aligned with the scan bodies. So we've gone through a process, we've talked about what to do. Steve, being the technical wizard he has solved this, and he sent me back something which shows me exactly how he's managed to align both the scan bodies and also the abutment level, the abutment scan that you see. And just a point to note here, again, to do with the accuracy of the prime scan. If you look here, what you'll be able to see is not only the top surface of the abutment, but you'll also be able to see that the prime scan is scanned inside the abutment. And you can see this where the screws would attach inside the abutment is visible because of the depth scanning properties of the prime scan. So again, you'll see that there, and you'll see me looking again. This is everything lined up. So with this, we go to the next step. We've got this library of link scans, and this is where some of the magic begins. And some of the magic begins with, these are the starting files you see. We've talked about the diagnostic wax up. We've talked about the shell. The next set of slides you see are the set of scans that we've taken. This is sent directly to Atlantis. And then from there, from that provisional prosthesis, what the technicians at Atlantis have worked out is how to, first of all, obviously link them and make sure everything works together. Then secondly, to figure out exactly how much support that zirconia needs and to design a frame so that actually the titanium frame is going to fully support the sleeve on top of it in terms of the zirconia that's there. What you can see here is slides from the lab of the bridge base with the top, you know, with the prosthesis. And what we get back at the next stage is this. This that you see here is the bridge base, and this is a PMMA shell or trine. And this allows me to just put this into the mouth and get the patient to look at it, check they're happy with it, make any final adjustments in case I haven't lined anything up. And once this provisional prosthesis, once this try-in, which is effectively a PMMA sleeve over the bridge base, has been approved by the patient, what we're able to then do is go through and make the final. And you can see here the final zirconia prosthesis. You can see a lovely dark red, you know, you can kind of quality to the gum that's there. And again, quick thanks to James Duncan at New Life Teeth for doing that. You can see again, there was a question earlier about the aesthetics of zirconia, and I have to say, when you look at the aesthetics that people are able to produce now, and this is monolithic zirconia that's only been stained, we're able to get really, really fantastic aesthetics with this. So again, we talk about this aesthetic predictability, going from one step to the other in a way that is controlled and easy and manageable. There is also another thing, which is if you imagine, I'm just going to go back a couple of slides, that for whatever reason you have a problem with your prosthesis, it's going to be a little bit easier to basically take that sleeve off and to remake that while keeping the base. There's a variety of different materials that you can use for this. But again, the advantage is suddenly if you have a fracture or a problem or a break, you're not having to remake the entire prosthesis, just a small part of it or just one half of it. And that part, the information is contained digitally within a library that you can keep, your technician can keep, Atlantis can have, which means that remakes become much less of a problem and much more manageable. And also, in 5 or 10 years, if your patient wants to refurbish their prosthesis, the refurbishment becomes, again, a little bit easier. So I think we gain access to the huge advantages from the digital workflow while eliminating one of the problems that we get. And again, talking through the process that you can see there, you can imagine having spare sleeves. Should the patient break the zirconia, I have a PMMA temporary already. I have the patient's provisional temporary as well. So should there be a problem, I've got 2 or 3 backups that I can use in case of an issue with it. So in talking about digital, we've got about, one of the things we're going to talk about is, okay, I talked to someone about this workflow that we'd been using, and he said, look, actually, I think we'll get there, but these are the issues that he sees. Repeatability, accuracy, verification, usability, and precision. And to give you a quick lesson, precision, you can see here, 4 different things, you can see 4 different things. You can see actually what you want is you want the arrow where you've got high accuracy and high precision. And what this looks at in the precision versus accuracy is we want to be both precise and accurate to allow us the best of both worlds. And again, when we're looking at studies, one of the things that's interesting, if you have a look, this slide is just going to show you several things. You're going to see generally when you look at studies that look at precision and accuracy, you've got you've got something there that, you've got the column, the height that shows you the accuracy, and then you've got the different scanners along the bottom. You can see here where there's different scanners have different properties. And what you want from these is you want scanner 1. What you don't want is scanner 4. And again, I've got to give credit to Phil Reddington at Beaver Dental Lab because he has a process where he gets his clinicians to do 2 scans. If the scans match up, i.e. if there is accuracy and precision, then he's happy to make the full arch restoration. If they don't match up, then he's got another pathway for them to go along. So in the past, the literature that we looked at stated that digital was not accurate enough. Digital wasn't as accurate as analog. So one of the questions that we ask ourselves is, okay, how accurate is digital? When we ask this, I think it's important when you're looking at studies that compare digital to analog, is that you bear in mind that when you're looking at digital, there's several things you need to look at. You need to look at the intrinsic accuracy of the scanner. You also need to look at this scanner operator. Can he scan well? Is there a good strategy he's using? You also need to look at the patient factors, the implant number, the position, the inclination, the depth. Large spans between implants are going to be harder to get accurate than shorter spans between implants. We also need to look at the scan bodies. How easy is it going to be to scan that particular scan body? Is the material easy to scan? We also need to have a look at how light the area is at the time you're working. And finally, you need to look at the congruence. How easy is it going to be for your technician to match up the scan body in the library on the model to the one that you've taken? So it begs the question to you, how accurate is what you're doing now if you're doing this in an analog way? And in talking about this, one of the things that we discussed, or one of the things that, one of the moments that I realized is whenever you do this part of the process, you might be 100% happy with the accuracy at this stage. But if we look a little bit further at about what happens, this model gets scanned, doesn't it? This model, that gets taken, a lab technician will typically put it in a scanner like this, and when he puts it in a scanner like this, actually that's the moment you go digital. So we're going to ask how accurate that part of the process is and compare it to the direct intraoral scanning. And also when you get this back, how accurate is the framework? is it particularly accurate? And when we look at the different methods for looking at framework fit, there's 5 or 6 methods that were looked at in this paper that you've seen in the previous thing, and we use a variety of different things. And what we realized, and what this paper realized, and what many other authors have realized, is that nothing fits to 0 microns. There's a tolerance. I've deliberately shown this slide because you can see the distal implant. You can see that the welding sleeve fits on top of the abutment. The component fits properly on top of the abutment. The implant that is mesial to that, you can see there's a gap. That gap is obviously not acceptable, and that was resolved before we made the prosthesis. But people have said that different authors have looked at it, and they've come up with a number. The number that came up in 2015 was about 100 micron. We're now looking at roughly around the 50 micron mark. So you cannot tell if something is within 50 micron. You can't tell, you can't tell less than 50 microns. There's also this paper by Professor Adam Nolte, and what he compares a lab scanner to intraoral scanners. And what I find interesting with this paper is in this particular paper where he looked at the lab scanners, remember the diagram I showed you where you look up and down at the accuracy? Actually, you see that some of the intraoral scanners are at the level of accuracy of some of the lab scanners. What this means, from our perspective, is that statistically, we know that the prime scan in his study, this is a quote from his study, was statistically similar to a level of intruders with the 3-shape E2 lab scanner. So if you have something that is accurate as your lab scanner, it's the same as scanning a plaster model bench side, or the lab scanning a plaster model and then sending it to Atlantis. So again, on the subject of accuracy, there's lots of different papers that say how accurate is digital, but I quite like this one by Mike Ludlow and his team, previously at the Medical University of South Carolina. But what they look at is they look at several factors, and this is a great study because what they've done is got the closest thing to a person, and they've scanned a maxilla. They've scanned a maxilla to the fixture head with 5 or 6 different scanners, and you can see you can see the detail of the scanners they've used there. And they've looked at different methods and different alignments. And what they've discovered is a few things. The first thing they've discovered is that actually, if you scan and you try and line up the complete surface of one scan to the other, you've got to bear in mind that what they did in their particular study was they got as the master model was they put that maxilla into basically an industrial level scanner, and that gave them effectively the control, and they compared that. And what they realized is that if you look at the scan body alignment, you reach below that magic 50 number with the prime scan that you can see there. And also the other thing they looked at is they looked at inexperienced and experienced operators, and they found there was a difference, particularly when you looked at complete surface alignment. So what they discovered is actually that experience is beneficial. If you exclude the soft tissue and you just look at the scan bodies, you're going to get much more accurate representation. They're not the only people to come up with these sort of numbers. You can see here Professor Stefan van der Werke has come up with, again, very, very similar research at the University of Ghent. This is him and his team. And again, if you look at the prime scan 5.2, that's 5.2 versus the analog, you can see we're getting to the point where, at abutment level, we're getting really, really close. And I think the other thing you need to ask is how much does this relate to your long-term clinical outcomes? And this particular workflow, I think, tells you something that you need to know, which is actually there's a level of acceptable fit. There's a level where there will be no clinical complications. There's a level of unacceptable fit where you will get complications. And the figure that we work to in the practice is roughly around 50 microns. And if we can get below that, which the prime scan has accurately demonstrated it can over those 2 or 3 studies with many more coming out, we know that we're in good territory there. So if we look a little bit further, just to again educate you, you can have a look and you can see here, this is the scan pattern that we talk about in terms of being able to scan one part and then the other part and going through the whole process. And I think the other thing that really, really has surprised me is we've been using the prime scan in this way, but we haven't just used it for bridge base, which again, we'll talk through in a bit. We've used it for FP1 cases that you can see here. And this has worked very well using a very, very similar workflow. We've also used it for, was the first case that we carried out. I think this was the first case, maybe worldwide, potentially, well, certainly in the UK, potentially in Europe, potentially worldwide, using this particular workflow. And, this fitted like a dream at the day we put it on. Again, many thanks to Steve and his team at Nexus for this. Again, we've also used it in cases where zygomatic implants have been placed. And again, the advantage of this workflow, by being able to have that predictability and by being able to have that bar, should there be complications, it is replaceable. And or it is serviceable in a very different way. The advantage of this and being able to get these aesthetics comes back to your patients. Being able to deliver aesthetically and functionally a workflow that delivers them from one step to the other, going all the way through. You can see here the particular patient we're talking about is something that they appreciate. And
what I would say to anyone who's considering implants is just go for it. Just do it. Don't delay. It's the best money I ever spent, and I absolutely love my teeth. They've given me so much more confidence and a new lease of life.
So it's more than that for our patients, isn't it? It's teeth, it's a lease of life, it's the ability to see their friends, it's the ability to go out on a Friday night, it's the ability to forget about how they looked and to move on with their lives and make sure that their teeth are no longer a part of it. And by having a place in which you've got a workflow, you can deliver this accurately in effectively 3, potentially 4 visits for your full arch, is something that's an advantage to you as a practice and an advantage to them as your patients. If we look a little bit further, what else is the other advantages? The other advantage is the range of materials that suddenly come in. I've talked about using zirconia. There's obviously PMMA, which is a type of, there's obviously acrylic that you can use, composites. There's lots of different materials that you gain access to in this workflow by being able to do this. And one of the things that, again, we're going to start using, and again, credit to Steve Campbell and his team at Nexus, is we're going to start trying using newer materials, which, graphene is a newer material that we're going to try using for this. And this may open up a huge range of different, possibilities that we can use for this type of restoration. So just going back to talking about bridge base, going back to where we started, what are the take-home messages for you? The take-home messages that I would put to you is that the technology is here now. It is here now. We've been doing it in the practice for 2 years at least. And also, it's not just us doing it. We're only one centre who had access to this technology and had access to this workflow. We're one centre. There's been people all over Europe and the States who've been doing this as well. So the technology is here now. It's been proved with PrimeScan, and there's a direct link between your PrimeScan via your lab to Atlantis to actually make these things. The second thing is that you need to use it properly. You need to scan properly. You need to make sure that, that there's protocols and processes you need to have to follow. And if you follow these processes and protocols, then you gain access to this technology and you gain access to the advantages. Like all things, if you take a poor impression, a poor digital impression, a poor analog impression, you will get a poor outcome from your laboratory. If you take a good impression, then again, you will get a good outcome from your laboratory. The final thing is that there's nothing that's perfect. There's advantages to using this workflow, there's disadvantages to using this workflow. And certainly in our mind and in our practice, the advantages have a huge benefit, both in terms of the aesthetic predictability, the availability of materials that you have, the ability to repair the prosthesis or to replace the top part of the prosthesis should you have a problem, and the reduced visits and also improved comfort for the patient. There's a huge advantages to this. So my call to you at the end of this is that you've done your surgery digitally. It's time now for you to enter the world where you carry out digital restorations. And going back to what Paolo Malo said, going back to that original slide, if we don't forget it, are we simplifying treatment? Yes, we're copying the provisional to the final. We're putting a lot of work into the provisional, but we're copying the provisional to the final. Are we reducing costs? We are, because we're reducing chair time, we're reducing the number of visits. And obviously, there's a huge advantage in terms of the business. Thank you very much for your attention today. You can find me if you want to know more. You can find me online at different, Facebook and also on Instagram on the following handles. And really, it's been my pleasure to be the last of the sessions here at the Decoding Digital Dentistry. It's been my pleasure. There's been many, many great speakers who've gone before me. If you've logged on just to this one talk, what I'd urge you to do is to go back and look through the other rooms. There are lots of other talks. There are people, you know, there's live sessions, there's a live CEREC, there's plenty on here. So if you've only just caught this, please do take a dive into the rest of the auditorium and the rest of the sessions. There are some great people on there. Thank you.
Amazing. Thank you, Martin, for an amazing session.
Oh, thank you, Lee.
It was really good. I was so engrossed in it, I forgot to keep writing questions down as I was listening to you go through it. We're really fortunate at Dentsply Sirona because we get you involved in an awful lot of new developments and new products. What do you look for before saying yes? Because obviously BridgeBase was quite new and you started at the very beginning 2 years ago. So what did you look for to get that yes?
I think there's got to be a clinical advantage. It's probably the same things that ask, what problem are we solving? The problem we were looking to solve is that we needed a way to be able to make full arch restorations using a workflow that would be easy to replicate and that was predictable. Our process, we really thought could do with some improvement, and the additional benefits to the patient in terms of the aesthetics were, was a massive, massive plus for us. So when we look at anything, when something comes in front of us, we say, okay, are we going to be able to use this in practice? Okay, yes. Once we use it in practice, is this going to be worth it for the return of investment, for the time, for the energy that we're going to put in? Because we're involved in this in a very, very early stage where there was a lot more than just send it off to the laboratory. There was a lot more conversation, etc. So we need to think, okay, if we are going to use this and we are going to find this reasonably easy to use in practice, then it's something that we'll get behind and think, okay, yep, this sounds reasonable. Let's look at it. Let's go further into it. And I think the other part that came is during lockdown. We did our first cases actually just before lockdown, but the other part that made me think actually really this is something we can do is during lockdown between I think Mark Ludlow, myself, and there was one or two other people in Europe that did this. We had this model we were sent and we scanned this same model, which was a 4 abutment model with uni abutments, and we all separately from 5 or 6 centers around the world sent the scan of a standard model back to Atlantis. And I think when they saw the data that came from that, which is separate people from around the world, different time zone, different days, are actually coming back. And when they're scanning with potentially slightly different methods, the data that they're getting was good enough for them to feel confident to offer this to everyone. And so that was a real, that was a real eye opener when that came along. That actually, in some ways, I think it's the words of Mark, who said, look, this is as accurate as a lab scanner. What you're holding, and I think you've seen the paper by Adam Nolte that says this is accurate as a lab scanner. So this is coming along, and I think that leap to go digital fully, the other part was prime scan, because it was at a different, we've got other scanners in the practice, this was a different level of accuracy that we had from it.
Yeah, it's a game changer totally.
It was. I mean, people use that word lightly, but I think in some ways we've been looking for this in implant data. We've been looking for, I want to do my full arch restorations digitally. I want to use my scanner and just make that. We haven't had it. And now we do.
Yeah, amazing. Yeah. And you mentioned though, obviously about the lab, and obviously this is not just a single decision because you need to think about the whole process. And luckily we have Steve Campbell, obviously from Nexus, which is amazing. Yeah. Do you two then have a conversation between yourselves about this is where we're heading, and what does that look like to bring him on board?
It starts with both of us thinking, okay, let's give this a go. There's generally a few times when, before we do it, there's several tests. So for instance, it's a shorter presentation, I didn't have time to go into it. But the first few times we had a metal bar milled to check the model, to check the data, and to just really make sure that we'd nailed every part of the process before we made the leap to do this digitally. It involves a lot of conversations. It involves a lot of WhatsApp. It involves a lot of Slack. It involves, I think, I'll give him credit, he takes quite a lot of time to think through something thoroughly before he goes ahead. And I think the other thing that's been really good with this process is just to make sure it's not through Steve's brilliance that we're able to do it, I've actually carried out the process with 2 or 3 different laboratories, and they've been able to make it, and they've been able to do it. So it's not, the process is there, and other people are able to do it, and other people are able to follow it. So that was another thing that was reassuring with Bridge Base.
Yeah, just reaffirms that
Yeah,
decision.
just reaffirms it's
Yeah.
not just I have to send it to Steve, because
Yeah.
you'd hate it if it was just one person in the UK that was good enough to do it. You need you need it to
It'd
be
be
a
very
process.
busy.
Yeah, he already is
Yeah,
very busy. It'd be even busier. Yeah.
Yeah, no, that's brilliant. And then, so we're launching Bridge Base to the wider market in January, fully. So that's going to be amazing.
Yeah.
What advice would you give to anyone that's going to start that journey?
I would say that if you have a prime scan and you're doing full arch, you're in for an absolute treat.
Brilliant.
You're in for an absolute treat. You know, you will be very nervous when you first start doing it, and you won't quite believe it happens, but it's now commonplace in terms of what we do. So before you start, look at the scan pattern. You know, really look at the scan pattern. Take time over the first few scans that you do. Make sure you get the whole of, with that initial scan, get the whole of the palate, get as much of the buccal as possible. Understand you need certain checks and balances within the system, a little bit like you do with analog. It's not just take a scan blindly and send it off and expect miracles. Go through the same checks that you would do. Go through the same phonetic, aesthetic and functional checks with the patient of the try-in. So make sure you go through a try-in stage.
Yeah.
But I'd say that, you know, we found the process really straightforward. Other people that we know who are now, you know, we're doing it, have found the process fairly straightforward.
Yeah.
So, you know, if it's January, I'd say, you know what, warm up your prime scan and get ready.
Get going. Yeah, definitely. I think that's really important, because we do say that the scanning protocol is so important.
It is.
And I suppose the first set of patients that you do it on, choosing the right patient to make sure you get the right result as well.
I would, and I'd say within that, you know, I have found that I found lowers particularly difficult. So I'd say for me, I think it's consistent on uppers, but not necessarily lowers. The other thing I'd say, it's consistent for me at abutment level, but at fixture level, you need a different level of precision, because if you're using internally coned abutments, you know, Ankylos, Astra, things like that, then it's much more difficult to get the level of precision needed. Although actually there've been some people who have done it on lowers at, you know, at implant level, and I, you know, full credit to them. But I think that it's a very successful and easy strategy to use at abutment level for the upper, definitely.
Yeah, I love that, because it's key that what works for one is sometimes slightly different to somebody else as well, and I think everyone will find their own flow with it as well. Thank you so much for today. It's been an absolute pleasure. And obviously I'm sure the whole audience has been enthralled by the entire process as well. And fingers crossed January will be really successful for us as well.
Well, best of luck with that, and thank you very much for the invitation.
No, thank you very much. I'd just like to say thank you to all of our speakers and contributors for the past 2 days. It's been a phenomenal show. And if you want to, you can still be within a chance to win a prime scan. So head over to the networking room and click on the link for the quiz. Answer all of the questions. You will find the answers in all of the live auditorium sessions, and they will go live in the on-demand area from Monday the 11th.